Are you a woman in your 40s and you've noticed that your antidepressant doesn't seem to be working as well? Your antidepressant used to work, maybe for years. You found the right medication, you found the right dose, you didn't have any bothersome side effects, and it made a real difference in improving your life. You felt stable and you felt like yourself. And then you hit your 40s and something shifted, even though nothing about your prescription has changed. But it doesn't seem to be doing the same job that it used to. Maybe you noticed some new emotional flatness, or your anxiety is up, or maybe you're not sleeping the way that you used to. And you wonder if somehow you built a tolerance to your medication, or if you need more, or maybe you need a different medicine, or this is just what life feels like right now. You might have even gone to your doctor and were told it's just stress and told to find more time for self care. Here's what might actually be happening. Your neurobiology has changed. When you are in perimenopause, the transition to menopause, that can really matter. So, today we're going to talk about why so many women notice this in midlife and what a more complete treatment picture looks like when your antidepressant just doesn't seem to be as effective as it used to be. I'm Dr. Susan Zink, a board certified psychiatrist and specialist in women's hormonal mental health, including mood and anxiety changes during perimenopause. So let's talk about what perimenopause does to the brain. Perimenopause, the years-long hormonal transition leading up to the final menstrual period, often begins in a woman's early to mid 40s, although it can start earlier. During this time, estrogen and progesterone don't simply decline in a straight line. They fluctuate unpredictably and sometimes dramatically before ultimately dropping as you get closer to and after menopause. And here's why this is important. Even though they are called reproductive hormones, estrogen and progesterone are not confined just to the reproductive system. They are very active throughout the entire body and brain. Estrogen supports the production and regulation of neurotransmitters like serotonin and dopamine, the same neurotransmitters that are most closely associated with mood, motivation, and emotional resilience. When estrogen fluctuates and declines, so does the neurochemical support. An antidepressant works in part by boosting those same neurotransmitters, but if estrogen is no longer doing its part to support that system, the medication is working against a changing neurochemical environment. The medication may still be helping, but it may no longer be enough on its own. Progesterone is the brain's natural calming hormone. Its metabolite, allopregnanolone, acts on the same receptors that many anti-anxiety medications target. So when progesterone drops, that built-in calming effect can often disappear, and anxiety, irritability, and sleep disruption can result. Many women in their 40s feel like they are falling apart. And what is actually happening is that their brain has lost significant hormonal support. Even though hot flashes are the most commonly recognized symptom of perimenopause, you might not know that mood changes are the second most common, occurring in approximately 70% of women. New or worsening anxiety, depression, irritability, emotional volatility, brain fog, fatigue, these are signs that your brain is responding to a real biological transition. You are not simply getting older, you are not just stressed, and you are certainly not imagining it. There's another piece of this that doesn't get nearly enough attention, and that is what perimenopause does to sleep. We know that sleep and mood are deeply connected. Poor sleep worsens depression and depression and anxiety can also worsen sleep. In perimenopause, multiple things are happening simultaneously that undermine sleep quality. And when sleep deteriorates, even a well-chosen antidepressant is kind of swimming upstream. So what changes are happening? Let's go through three big changes. Number one, melatonin production declines with age. The pineal gland, a small gland in the brain responsible for producing melatonin, which is the hormone that governs the sleep-wake cycle, begins to calcify and harden as we age. And the result is a measurable decline in natural melatonin production, which makes it harder to fall asleep and to stay asleep. This is just a physiological change and has nothing to do with your sleep habits or your sleep hygiene. Number two, not only are we often losing the direct natural calming effect of progesterone, but also progesterone and cortisol have an inverse relationship. When progesterone drops, cortisol tends to rise. Cortisol is our primary stress hormone, and it naturally spikes in the early morning hours and tells our bodies and brains to wake up and get ready for the day. When progesterone is no longer at normal premenopausal levels, cortisol can go a little haywire, often causing women to awaken at 3 or 4 a.m. with a racing mind and making it really hard to get back to sleep. This is the classic perimenopausal wake-up pattern, and it has a direct biological cause. And number three, obstructive sleep apnea rates skyrocket in midlife. This one surprises almost everyone. Obstructive sleep apnea, a condition where the airway partially collapses during sleep, causes repeated microarousals, and it becomes dramatically more common in perimenopause and postmenopausal women. Why does this happen? Estrogen and progesterone help regulate muscle tone throughout the body, including the muscles of the airway. And when those hormones decline, airway muscles become less toned, the airway narrows, and the risk of obstruction rises significantly. At least 1/3 of women in perimenopause describe significant sleep problems, and between 1/3 to 1/2 of postmenopausal women have at least mild obstructive sleep apnea. This is 2 to 3 times more common than in premenopausal women. You may not even know you have it. Obstructive sleep apnea doesn't always look like dramatic snoring, and you don't have to have obesity to have sleep apnea. It can look like waking up unrefreshed despite sleeping enough hours, or excessive daytime sleepiness, difficulty concentrating, or even just a change in mood that seems disproportionate to your circumstances. Obstructive sleep apnea is the leading cause of excessive daytime sleepiness, and it is highly treatable once diagnosed. So if you're sleeping enough hours but waking up unrefreshed, or you're snoring more than you used to, or feeling like no amount of sleep touches your fatigue, a sleep study is worth discussing with your doctor. Sleep apnea can certainly make depression hard to treat, but it can also have other long-term health risks if untreated. So this is really important. And number four, a little bit of a bonus, other sleep disorders also increase. Restless leg syndrome, for example, which is an uncomfortable urge to move the legs that worsens at rest, and particularly in the evening, becomes more common in midlife too. Low ferritin or low iron stores are one of the most common and correctable triggers, and it is frequently overlooked. So let's put all of this together. Declining hormonal support for mood and sleep, unpredictable fluctuations that destabilize neurochemistry, rising cortisol, deteriorating sleep architecture, and the compounding psychological weight of midlife, career demands, caregiving, shifting relationships and identity. You can see clearly how an antidepressant that was working well in a different hormonal context and life stage may no longer be sufficient on its own. I like to compare antidepressants sometimes to a fertilizer. They help the garden to grow, but when the soil is starting to dry out or you don't have enough seeds or water, then the fertilizer just isn't going to work as well. So what can we do about it? The good news is that there is a lot that can be done, and most of it involves looking at the full picture rather than just one piece of the pie. So number one, consider hormone therapy. For women in perimenopause or the menopause transition, menopausal hormone therapy deserves a serious conversation. And it's not just for hot flashes, but for mood, sleep, cognitive clarity, and quality of life, along with a lot of other health benefits. Of course, the decision is individualized and nuanced, and it involves weighing benefits and risks specific to your health history. Not everyone is an ideal candidate, but dismissing it without a real conversation means leaving a meaningful tool off the table. And we have a lot more research recently on the risks and benefits of this treatment tool. I'll go into much more detail on hormone replacement therapy in later episodes. Number two, consider a sleep study. Given what we know about sleep apnea and other sleep disorder rates in midlife women, If your sleep quality has declined, especially if you wake feeling unrefreshed, have daytime fatigue, or notice more snoring, a sleep study is a reasonable and important next step. Obstructive sleep apnea is treatable. CPAP or continuous positive airway pressure is sometimes necessary, but milder cases may respond to a special dental appliance that helps keep the airways more open. And treating sleep apnea can have a meaningful effect on mood, energy, and cognitive function, and protects your heart and lungs too. Number 3, run comprehensive labs. A standard panel often misses things that matter. My approach includes looking at thyroid function, a complete blood count to check for anemia, optimizing ferritin levels and iron stores, which are important for restless leg and energy, vitamin D, vitamin B12, glucose, and insulin, among many other things, depending on your specific symptoms and history. Deficiencies in any of these can worsen depression, fatigue, and cognitive symptoms, and correcting them can make a really meaningful difference. Number 4, get morning sunlight. Morning light exposure helps regulate the circadian rhythm, which, as we discussed, is often disrupted in perimenopause. But it also has a direct mood benefit independent of sleep. 20 to 30 minutes of natural light in the morning, ideally within an hour of waking up, is a simple and well-supported intervention. Number 5, prioritize daily movement. Exercise is one of the most powerful tools we have for mental health. Research shows that consistent, moderate exercise can be as effective as medication for mild to moderate depression and anxiety. It increases endorphins, serotonin, dopamine, and norepinephrine, and it also increases something called BDNF, or brain-derived neurotrophic factor. This supports the growth and maintenance of healthy brain connections. And exercise does not need to be super intense. A daily walk counts. There's a lot of research behind the benefits of yoga and strength training too. So start small. Every little bit counts, and you will build momentum, strength, and energy with time. Pick something you enjoy so it can be sustainable and doesn't feel like a chore. Number 6, invest in social connection. Social connection is not a luxury. Research consistently identifies it as a significant protective factor for mental health and longevity. In midlife, when schedules are full and relationships can gradually deprioritize themselves, intentional investment in connection matters clinically, not just personally. Number 7, improve nutrition. The gut-brain connection is well established. The gut produces a substantial portion of the body's serotonin, and a diet that supports the gut microbiome supports the brain. Fiber, quality protein, healthy fats, varied vegetables, seeds, fermented and probiotic containing foods are important. And this doesn't require perfection. You don't have to make a huge overhaul all at once. Pick one thing, like it's a menu, and then add as it becomes easier. And finally, revisit your medication. If you've done all of the above and your mood still isn't where it needs to be, it is entirely appropriate to revisit your medication. The dose that was right for you 5 years ago in a different hormonal environment and different life circumstances may simply need to be adjusted. There is no shame in taking an antidepressant. They are powerful, evidence-based, and in many cases, life-changing tools. The goal is not necessarily to take less medication. It is to make sure that whatever you are taking is working in the context of a complete treatment picture. And most importantly, to help you thrive rather than just survive. And here's one more thing to consider. Consider adding psychotherapy if you're not already doing it. Medication and lifestyle changes address the biological and physiological dimensions of this transition. Psychotherapy addresses the psychological ones, the grief, the identity shifts, the relationship changes, the meaning making that midlife often demands. Research consistently shows that medication and psychotherapy work best together. They have a synergistic effect, not just an additive one. Both therapy and medication help the brain to make new connections and rewire in healthy ways. If your antidepressant has felt less effective lately and you're in your 40s, I hope this gave you a framework for understanding why and a starting point for what to do about it. You're not imagining it and you're not out of options. Next week, we're going into sleep in perimenopause in much more depth. What's driving it and what actually helps? That one is for anyone lying awake at 3 a.m. wondering what happened to their sleep. Subscribe so you don't miss it and drop a comment if something resonated. I'll see you next week.